I am Hayeon Kim, medical physicist at UPMC Hillman Cancer Center. My talk is about the cost effectiveness of SBRT for spinal mets. Outline is the I will introduce a brief of a background of economic evaluation for in general for radiation therapy, also cost effectiveness and its components, and the Markov model as a decision model for the health economics. And I will present one of my previous paper, which was about cost effectiveness analysis in vertebral bone mets. And then final topic will be the work on progress. Currently, we have way better and more prospective data available for the bone mets with the SBRT. So that my cost effectiveness analysis is being updated. So the background, as we all know, very rapidly there is an evolution in radiation therapy. It has been so wonderful and exciting. However, we also need to pay a lot of more money or increase in cost to patients, payers, healthcare, and all society. That's why there is a growing interest in economic evaluation for all the new technologies in radiation therapy. However, it comes with a cost. So now we can say, hey, costly or cutting edge treatment technology always offer better outcome. So what do you mean by better outcome? How do you quantify or how do you evaluate better outcome? So that so we can quantify and evaluate the value-based care, which means healthcare outcome obtained per dollar spent. So their cost effectiveness analysis is considered an important tool for incorporating economic considerations into clinical decision making. It informs payer benefit of treatment. Also, it provides analysis of the consequences of treatment choices. It also quantifies new interventions relative value. For example, we have treated only external beam for spinal mets, but recently we treat with the SBRT. So how much SBRT giving us the value? That's what we can do with the cost effectiveness analysis. Final purpose of the cost effectiveness analysis is attempt to make most efficient use of resources. So components in cost effectiveness analysis are the treatment strategies. Of course, we have to compare treatment method A versus treatment method B or more. And perspective of analysis, this is more likely from the cost, what type of cost we want to use for the analysis. And time horizon is depending on the outcome data available, some outcome available 2-year outcome data or 5-year outcome data or 10-year outcome data, depending on the best possible evidence, we can set the time horizon for the modeling and also data synthesis. We have to gather all the best possible data for the cost and effectiveness data, which means more likely quality of life data from the patient. Also, decision model has to be set up. So decision model cannot be just write up at your own. You have to use the certain decision modeling tool software. So there is a little bit of coding involved. And results is always presented as ICER, which means incremental cost effectiveness ratio. And also when we evaluate the ICER, we have to have some criteria which is used for the like a cost effectiveness So willingness to pay threshold is used. In USA, we use normally $100,000 per quality adjusted life year gained, because this is more likely conventionally cost effectiveness is come with the twice per capita income. In USA, it's about 100K. That's why. So if our result is less than $100,000 per QALY, that means, this strategy or intervention is worthwhile to try in terms of economic standpoint. Last portion of the component is sensitivity analysis. As we all know, when we combine all the data available for the outcome data for the modeling, data cannot be point estimate. It always have a mean value and all the ranges we have to consider. So that gives us that the model uncertainty. That's why we have to include the sensitivity analysis as well. So cost is a huge part, as we all know. So usually cost is direct medical cost, non-medical cost, time cost. Those are big three components of the cost. However, in USA, we go by direct medical cost only for the cost effectiveness analysis because Medicare reimbursement shows clearly the quantification of each treatment method, procedure, and delivery, every daily life direct cost. It's quantified. That's why it's easy to pull up and use it. Non-medical cost is more likely out of pocket from everybody, and time cost is also for the time and productivity loss or like away from work, all those time or traveling time. So total cost should be combined all of them, but it's impossible to combine all of them. That's why we go by Medicare reimbursement cost, which is considered the macro costing. And then this is considered the proxy for true cost. That's why cost effectiveness analysis is done with macro costing, which is Medicare reimbursement in USA. And also we can say it's payer's perspective or healthcare service perspective. Micro costing is including every single detailed cost for delivery of care, but there is not possible to get accurately. This is one of my paper in 2015 published in Red Journal. So this table two particularly shows that the external beam 1 fraction 8 gray, SBRT 1 fraction 16 or 18 gray, we got the reimbursement data in as of 2014, because this is 6 years ago we did the analysis. And then as you see, total Medicare reimbursement is about $1,000 for EBRT 1 fraction, SBRT is $9,000. So Medicare reimbursement reflects that the SBRT is 9 times higher than the EBRT 1 fraction in terms of all the procedure code, and then it gives a lot difference in terms of dose delivery and then also simulation and dose calculation wise. And also treatment effectiveness part is more likely from the quality of life utility values. So recently, the patient-centered endpoints to assess the quality of cancer care is very emphasized by all our radiation oncology or oncology community. Also, health-related quality of life means also economic benefits of the treatment. So Markov model is the one of decision analysis for the cost effectiveness analysis. It's kind of a mathematical representation of all the clinical events. So we need to know how to code for the modeling. So this is the my previous cost effectiveness analysis comparing external beam single fraction to the SBRT single fraction palliation of vertebral bone mets. Actually, at this time, what we did was that at the time, RTOG 0631 trial was ongoing. There was no results available yet at the time. So that we used the trial hypothesis primary endpoint. So the SBRT will give better pain relief compared to EBRT by 40% in relative difference. And then also at that time, not only that trial, also we combined all the other retrospective trials and then all the outcome data combined, and we got the clinical parameter set up. Perspective was Medicare reimbursement, macro costing, payers perspective. Since patients' median survival was quite low, so we followed in the modeling, all the cohorts were followed until all patients die. Data was clinical outcome data, of course, so such as median survivor, complete response rate, partial response rate, toxicity, or like a retreatment rate, all those were pulled up from the literature, and quality of life utility measures and Medicare reimbursement, as I showed in a couple of slides before. This is the kind of like a bubble diagram for the Markov model. So I see that the 6 different bubble, each bubble shows that the health state for this treatment. So patient go through either external beam or SBRT, and then patient would go maybe pain relief, maybe pain, unrelieved pain, maybe retreatment. Also based on the median survival, we could put a certain portion to the dead state. So after treatment, retreatment, the patient may get pain relief or still not getting any pain relief. Pain never be relieved or something like that. So based on all the clinical parameter, we plug into the probabilities in this arrow, and then we calculate the cost effectiveness. So at that time, 2015, we got the result, SBRT single fraction was not cost effective. At the time, we put the also median survivor. It's the same between both treatment arms. However, sensitivity analysis showed model results were very sensitive to quality of life utility values and median survivor. So quality of life utility values all over the place whenever you pull up from any publication. So when you go to the variation of survival, that's better concrete parameter to see a change of model results. So that at the time, we put the base case median survival as 9 months. But when we put the even 2 months more survivor, SBRT was cost effective compared to external beam single fraction. If it's 18 months or more, it was way below cost effectiveness analysis goodbye value. So at that time, our results was that SBRT was not cost effective. However, when median survivor was expected to be higher than the base case, SBRT, selective SBRT used for patients with longer survivor was a very economic approach. So now my last part of the cost-effective analysis study for spine mets is that my previous study was published in 2015. That means RTOG trial was still ongoing, but unfortunately, RTOG this trial results came out, and then they said that there is no pain relief difference between EBRT and SBRT. A little bit strange, but anyway, good thing is that we could get the more prospective trial data recently for spine mets. Earlier this work was Dr. Sagar presented his like a data. So we used Dr. Sagar's Lancet Oncology data, and then Spravi's data, and also Opus 1 study data. So all these 3 modern prospective trials show that some different outcome with the SBRT for pain management. So at this time, we still used the treatment strategy comparison for the single fraction EBRT 8 gray. However, SBRT dose is higher than my previous study, which is that the 2 gray times 12 fraction. And also this time, based on the Opus trial, we also put the ablation, so that the 3 different treatment strategies were compared. For the scenario sensitivity analysis, which reflects the various clinical practices in this world. So some people still treat with 5 fraction, not single fraction. Also, SBRT 2 fraction was our base case scenario. However, we also used this. What if we use a single fraction only SBRT? And final assumption was that what if we assume SBRT is a higher survivor based on the these days like oligomets trials showing the promising result for the survival gain with SBRT. So this is a little bit busy slides, but I just want to show you guys clinical parameters for Markov model. So all the median survival, complete pain response rate, or like a retreatment rate, or toxicity rate, and utility values, all are plugged into the Markov model, and then we do the analysis. Next slide will show also cost. Medicare reimbursement cost as of last year. This is our updated cost. So updated CEA still shows SBRT wasn't cost effective. Also, radiofrequency ablation was very expensive treatment compared to SBRT and single fraction EBRT. However, sensitivity analysis shows that the model was sensitive to a variation of the complete response rate. So if a higher complete response rate will give a better result, of course, and quality of life utility values for the pain, which was very similar to my previous analysis. And the third one is median survivor. So here is the scenario analysis. 2 fraction SBRT was not cost effective, as I just mentioned. However, when we use the data from the SBRT 1 single fraction, it was cost effective. Also, more promisingly or more importantly, if we assume survivor improvement with SBRT by 3 months, 6 months, 9 months, it's well below cost effectiveness criteria. This is not published yet. We are about to submit to the peer review journal. So briefly, I can, tell you that the single fraction SBRT was more cost effective than the 2 fraction SBRT and ablation. However, when we assume that the survival gain with at least 3 months for SBRT, 2 fractions of SBRT would become cost effective. Therefore, SBRT for spine bone mets is cost effective in the setting of a survival benefit for oligomets disease. Actually, in previous couple of talks also emphasized, as I remember, emphasized that the well-selective patient group for the SBRT is important. That's kind of my analysis also same line with that. So Dr. Sushil Beriwal is always great helper and mentor and everything. And thank you.